Hello, everyone. This is the Scottsdale Institute, and thank you all for joining us today. We're very excited about today's teleconference. It's a fascinating topic that we've all been exploring in different meetings around how do you harness the power of analytics, big data, artificial intelligence, machine learning, et cetera. And we've got some great insights today from our partners at Nuance, Dr. William Boonn, the Chief Medical Information Officer over Healthcare Diagnostics from Nuance, and also Dr. Ben Wandtke, the President of the Medical Staff and Chief of Diagnostic Imaging at the University of Rochester Medical Center. They're going to share their insights as well as some recent research that they've been doing, and I look forward, and I'm sure you do as well, in hearing all that they have to share today. So Dr. Boonn and Dr. Wandtke, thank you so much for joining us today, and you can start at any time.
Great. Thank you, everyone, for joining today. And again, on behalf of the Scottsdale Institute and Nuance Communications, I'd like to welcome you to this afternoon's presentation. My name is Bill Boonn. I'm a diagnostic radiologist at the University of Pennsylvania, as well as Chief Medical Information Officer at Nuance Communications. I have the distinct honor of introducing our speaker for this afternoon's presentation, Dr. Ben Wandtke. As was mentioned previously, Dr. Wandtke is the President of the Medical Staff and Chief of Diagnostic Imaging at FF Thompson, which is part of the University of Rochester Healthcare System. And the talk today is entitled, The Power of Using Clinical Analytics to Drive Follow-Up on Incidental Findings. This talk comes at a really appropriate time as November is Lung Cancer Awareness Month, and many of the radiology examinations many of the incidental findings that we see on radiology examinations are pulmonary nodules, and there is a significant impact on clinical outcomes and patient outcomes based on whether these incidental findings are cared for appropriately. So if you jump to slide number 4, that's our agenda. Dr. Wandtke will begin the presentation talking about a clinical case and some of the issues surrounding delays in diagnosis, preventable medical errors, and incidental findings. He'll then discuss the Backstop project, which was designed to address failed follow-up. I will jump in then to talk about the value of using mPower clinical analytics. And finally, Ben will finish up the presentation talking about outcomes and some take-home points. So without further ado, I'd like to introduce Dr. Wandtke.
Thank you, Bill. Appreciate the opportunity to speak to everyone today about a topic that's near and dear to my heart. I have one disclosure. The work that I'll be talking about today, our Backstop project, is partially funded by our malpractice insurance provider, MCIC Vermont. So I'd like to start this talk with a case. This is a patient that came to our emergency department about 5 years ago, and this really started our journey along managing incidental findings. So this was a 60-year-old female, came in with chest pain to the emergency department. On slide 7, you'll see that there's a small lung nodule, nodular density was identified in the left lower lobe, and our radiologist identified this, called this to the emergency provider, recommended a follow-up CT for further characterization to make sure we didn't have lung cancer that we were dealing with, and documented that in the radiology report. So we did everything we were supposed to do in radiology, but unfortunately we never saw that patient again. They were lost to follow-up. There was a gap in communication between the ED doctor and the patient's primary care provider. The next time the patient was seen in radiology was 3 years later. And on slide 9, you'll see that she came in with chest pain and hemoptysis this time to the ED, and unfortunately had about a 4-centimeter mass that had already spread to the liver and the bones and was diagnosed with stage 4 cancer. And despite aggressive treatment, this patient lasted about 1 year before unfortunately passing away. If that were one case, we wouldn't be talking today, but this is actually more common than you'd like to think. In one community hospital, we identified about 6 cases in a 2 to 3 year period where gaps in tracking or follow-up of these incidental findings were leading to significant delays in cancer diagnoses. Each one of these cases on the top shows a small lung nodule that was identified, and recommendations were made for follow-up, but unfortunately not acted upon. And in each case, the patient ended up presenting with an advanced stage, basically untreatable cancer. So I want to talk about improving diagnosis. So on slide 12, you'll see that our journey in quality really started in earnest in 1999 with the Institute of Medicine's report to Err is Human. Really is the first time we sort of accepted the concept that health systems are imperfect, that the amount of deaths related to medical errors were very significant, and that individuals could not solve the problem, that we needed to develop systems of care that were safer for our patients. On slide 13, you'll see that the follow-up to that, the Institute of Medicine came out with a report, Improving Diagnosis on Healthcare. This doesn't get as much attention around in the healthcare world, but this is an important topic. So it focused on the concept of diagnostic error, defined as inaccurate or delayed diagnosis. And it noted that this remains a blind spot in the delivery of quality healthcare, in part because it's more difficult to measure and to do research on and to improve. Diagnostic errors contribute to approximately 10% of patient deaths, and they are the leading type of paid medical malpractice claims in the primary care setting. The American Medical Association did a 10-year review of research in ambulatory patient safety in 2000 to 2010, and they identified a couple of things. One is that radiology recommendations or incidental findings were not resulting in the completion of recommended imaging tests very frequently. About 50% in most institutions of our recommendations never lead to that recommended exam being completed, and that 1 in 7 patients who were diagnosed with lung cancer were suffering a preventable delay in diagnosis. This is either due to providers not picking up appropriate classic signs and symptoms of lung cancer and delaying the imaging, or noncompliance with imaging follow-up due to gaps in communication or tracking systems. Why are incidental findings so important? Why are we talking about them today? Well, one, they're very common. And although most are benign, others represent early treatable forms of cancer. And then the trick is to figure out which ones are which and to order a test appropriately to manage these. But they are an opportunity. Not, for years we've thought of these as a frustrating thing. We see all these incidental findings. We didn't have a lot of good data about what to do with them. We're getting a lot more evidence and consensus-based criteria about how to manage these appropriately. There used to be a lot of variability in the type of recommendations coming out. We're getting better at making more consistent recommendations, and it was more tests to be ordered, more work for everyone to do to keep track of these things, because we didn't have great systems set up to identify who needed these follow-ups and when they needed to be done. When we got the information as a provider isn't the right time to act. We have to wait and then act later, a more comprehensive way to treat the patient. And it didn't fit well into our episodic care models that we've had. But there's an opportunity in every problem that this can be done better. And I'll talk about that a little bit in the future about how we tackled that. The management of incidental findings was the source of frustration, and that in part because a lot of these tests weren't being accomplished. So if you look on slide 16, I want to talk about the impact of a delayed diagnosis on an individual patient. So think about that case I showed you first. This is a Kaplan-Meier curve. It's got survival probability on the left and years from the time of diagnosis on the right, and the different lines represent the different stages. Obviously, stage 1 and 2 is early stage cancers, and stage 3 and 4 on the bottom are advanced stage diseases. On slide 17, you'll see that incidental findings I represent by the people that are walking towards the top of the curve. Every time we see an incidental finding, they're typically on the order of a centimeter or smaller. These, if we diagnose them as cancer at this time, they typically can be diagnosed as an early stage cancer, stage 1 or stage 2 cancer. And if we identify those patients should walk the top line, which is about 50% 10-year survival for lung cancer. This being Lung Cancer Awareness Month, and lung cancer being the most common cause of cancer death for both men and women in the country. If you look on slide 18, the problem we have is that there's gaps in communication at transitions of care and other reasons why these incidental findings are not being followed up or not being tracked appropriately. And some of these patients are what we call falling through the cracks. So there's gaps, and these gaps are taking patients that should be out walking this top line in terms of survival and putting them down towards the bottom line. In those 4 cases I showed you, they didn't get to walk the top line. They had to walk the bottom line. And that's a 50% survival impact for each of those patients affected. And there's really no, as advanced as medicine is getting, our expensive treatments, chemotherapies, and surgeries, they had months or maybe a year to life, but they don't really, there's no treatment we have that puts somebody back up to that top line in terms of their overall outcome. So it's much better to identify the problem before it becomes before the advanced stage cancer can spread. There's simply no way to get them back to the same outcome as an early diagnosis. So our vision on slide 20 was to close the gaps. We want to fix the holes in the system. We thought it was not fair for some patients to get suboptimal care because of inconsistent communication. And this got the attention of our malpractice insurance provider because, as you see on slide 21, these cases are difficult to defend in court. There's often a paper trail that shows that a recommendation was made, and there's really no defense to say why we didn't do it. Oftentimes, we simply lost track of it. And in this case, there was a case in South Carolina where a urology practice was ordered to pay $10 million because they lost track of an incidental renal lesion that ultimately ended up being renal cell cancer, and by the time they diagnosed it 2 or 3 years later, it had spread to the inferior vena cava and was unresectable. So why does this happen? Again, going back to this American Medical Association study, was that we lose track of test results. They're either not communicated to the emergency or to the patient's primary care provider. They might have gone to the emergency doctor, or they're delayed in the time that they get out. Offices often have a few resources, office-based practices, in order to track their incidental findings. There's some tools in electronic medical records, but they're not great. They often have a single point of failure. So if they try to contact a patient once and the patient doesn't respond, there's often not a second or third level to come back and to continue to work on that or identify that this is that a patient is at risk for a delay in diagnosis. Many times patients are not notified of their test results in the emergency department or when they're being admitted as being cared for by a hospitalist, or if they're in the ICU. Sometimes there's unclear responsibility when multiple providers are caring for one patient. This often happens when they're out to see a subspecialist for one particular issue that orders a test that comes back with an incidental finding, and the specialist thinks that the primary care provider is going to take care of it. And the primary care provider says, well, that test was ordered by the specialist. They're going to see that. They're going to take care of it. And we talked about transitions of care, and there's other patient factors that are a little bit harder to get to. The financial implications of getting the test, transport, language barriers, etc. So we sat down and tried to figure out, how do we prevent this from happening again? How do we eliminate these delay in diagnosis? So that led to the project that I'm going to speak about today. We call it Backstop. And we started back in 2015 at one of our community hospitals. We wanted to design this as a safety net. We didn't want to replace all of the office-based tracking systems, but simply identify which people were falling through the cracks, identify those in a timely manner, and work collaboratively with the primary care providers or other office-based providers to remind them and to help them do some of the quality work around tracking these patients. The standard of care is to communicate, for a radiologist, is to communicate the incidental finding to the referring provider. But this was often an emergency department physician or hospitalist whose workflows are simply not designed to manage incidental findings. So any system that works on simply improving communication to the referring provider still leaves a lot of gaps in the entire process before somebody's actually going to get that study ordered and completed. We wanted a high reliability design. We wanted to identify these failures when they were small before they ballooned out and ended up with a advanced stage cancer. So we started with a minimally intrusive intervention, and I'll explain our system in a few slides. And then we ultimately moved on towards more intrusive interventions for patients that were more difficult to intervene upon. We have an inclusive design for patients. It's not patient-centered. We deal with the office-based providers first. Ideally, the health system should work well for patients, but when it doesn't work well and we have a difficult time to come to a satisfactory conclusion for the patient, we feel that they're still at risk for delay in diagnosis, we always inform the patient through a letter. We wanted a system that was agnostic to the electronic medical record. And while there's a lot of benefits of working through an electronic medical record, about 30% of our referral base was not part of the integrated health network, did not work in the same EMR, and it would have been difficult to connect those people into the same system. We didn't want to build a system for 70% of the problem that left 30% out there. So we started with a system that was worked outside of our electronic medical record. and we wanted an outcome-focused system. I talked about, a lot of people in dealing with incidental findings are working on improving the communication of the findings. We wanted to focus more towards an outcome and focus on the actual completion of the examination. On slide 27 here, you'll see our inclusion criteria. So we basically are looking for anything that's potentially cancer or an aneurysm, anything that can kill you if we lose track of it. And these, we have a lot of recommendations in radiology that come from the Fleischner Society for Lung Nodules. The American College of Radiology has a lot of standard evidence and consensus-based guidelines for incidental findings. And there's some other society groups as well that come up with some guidance documents for us. For a hard endpoint for a tracking intervention, it has to have a couple of criteria. It has to meet a couple of criteria. One is that it's that it has a specific imaging modality recommended and a specific recommendation due date. Not all recommendations have these, but we can consider those that do to be actionable. And we want them to have no hedge statements or to be an unconditional recommendation. There are some recommendations that say if the patient has bone pain, I recommend a bone scan. Those are difficult for somebody who's without a medical knowledge to really identify did that event occur or not. So we focused on the most severe recommendations first. These were the ones that, such as what comes out of the Fleischner Society guidelines, you'll see in the bottom of slide 27, CT chest without contrast recommended in 6 to 12 months. So those are very hard, actionable, and trackable recommendations. You'll see on slide 28, there's a graph on the right. So we looked at all of our recommendations that we made as an institution. I said incidental findings are common. For all of our diagnostic imaging tests, we made a recommendation in about 4.4% of all of our studies. But about half of those had an unconditional recommendation or were missing a hedge statement or did not have a hedge statement. So those are a little bit stronger recommendations. And of those, only about a quarter of those unconditional recommendations at our institution were trackable. They had a very specific imaging modality and a specific recommendation due date. And these are the best recommendations, again, because if you're lining up with a best practice or evidence-based criteria, you're going to end up with a recommendation that has both an imaging modality recommended and a due date. So part of our project was to increase the rate of trackable recommendations with our radiologists through education and training, but I'm going to avoid part of that today. It gets into a deeper talk. But I'll talk about what we do with the recommendations once we do identify a trackable recommendation. So first, we put them into. You have to have a method to identify the recommendations, and we started out with a manual process. For us, we originally just flagged these in our dictation system and manually entered those into a database. But over time, we developed a system where we can click a button in the radiologist workflow in their PACS environment that says they have a follow-up recommendation, and it has a pop-up field here that describes what is the finding that the recommendation is based upon, what one or more follow-up study types would be sufficient to close out that recommendation or would answer the question, and what is the due date. And these are mandatory fields, and once a radiologist selects those mandatory fields, the recommendations are automatically entered into our database. So the database we've developed is seen on slide 30, and it contains all the information automatically entered about what is the patient's primary care provider or provider that we're tracking it with, who is the reading radiologist, what is the type of, whether it's a lung nodule or pancreatic cyst or adnexal cyst, what follow-up imaging test was recommended, what was the recommendation due date, and a number of other steps for our navigator who tracks these interventions to know when to intervene. And this database will give the navigator or our tracker who manages the database a list every day of the recommendations that are overdue that need some sort of intervention. So I've talked about our intervention. So what do we do to intervene? So we started with a 3-stage system. We don't do any interventions until 1 month after the recommendation due date. So we let the current system work. We work as a safety net, and every office has some type of tracking system. So we have access to the radiology information system as a health system and as a radiology department. So we look first there. We also look in the electronic medical record and do some chart review to see, is there an explanation? Did the test get performed? And if it didn't, what did it get performed outside of our institution? And can we identify that, or was there some discussion with the patient, such as that the patient was, towards the end of life with a limited life expectancy or on palliative care, or have they had it surgically resected or biopsied or some other reason why they don't need medically to have this recommended imaging test done. If we can't identify that, we resend the radiology report to the patient's outpatient office, usually the primary care provider. And we send a cover letter that explains that there's an overdue recommendation, and that here's the report, and they can read about it, and we give them a phone number and an email contact that they can let us know if something occurred, an event occurred like the patient had the imaging test at an outside institution or some other reason for why they didn't complete that exam. We wait another month. Then if 2 months after, again, we recheck the radiology information system and the patient's electronic medical record. If it still hasn't been performed, this time our navigator, who is a medical secretarial training, but does this as a full-time job now for our health system across 6 hospitals, she picks up the phone and calls the patient's, calls the office-based provider, either a nurse or a care manager, to have them pull the chart if it's an EMR that's outside of our system, or to have a discussion so they can leave a note for the patient's healthcare provider that this recommendation is overdue. And then we wait another month, and then if it's gone 3 months, then the radiologist who made the recommendation will now call the patient's primary care provider directly and have a conversation about why we think this recommendation is important to be followed up. That's an interesting one, because oftentimes when we call a primary care provider, their first response is, I've never had anyone call me like this. And it seems to be a good opportunity for radiologists to show some value outside of what the traditional role of radiology is. And like I said before, at any point in the process, if we can't get a completion with the office-based provider, we would just send a letter to the patient letting them know that there's an overdue recommendation. And on slide 32, you'll see an example of what our letter looks like. It auto-populates with the date, the patient's name, the exam date and type from where the recommendation came, at what facility, and some contact information to speak with our Backstop team, and they can get information about financial assistance to get the test done, to how to get a primary care provider if they don't have one, and some other information off of our website. It includes the name of the radiologist, as well as a way to reach back and get a phone call from the radiologist if they have a specific question for them about the recommendation. So how effective are all of these interventions? So everybody's learning about which interventions work, and I don't claim that Backstop has a perfect series of interventions. It takes a long time to identify what works and what doesn't. We have more data than most institutions because we've been doing this longer. But on slide 33, you'll see that the least intrusive interventions, just resending the radiology report, which is our stage 1 intervention, was 29% effective at getting either a satisfactory, either exam completion or what we call clinical closure, which is identifying a rational medical reason not to do the test, such as palliative care, end-of-life decision. Our stage 2 intervention, where the navigator called the office and spoke to a nurse or care manager, was 52% effective. And there's a little bias in here because the people that reach stage 3 are really difficult recommendations to track down. And this is only about 9% of all of our recommendations made it to stage 3, but those that did, we had a 58% chance of getting a satisfactory closure with the radiologist making a call to the patient's primary care provider. So when you wrap those all together, over the 13-month period of our pilot project, we ended up tracking almost 600 recommendations to completion. We had a baseline exam completion rate of 46%. That meant 54% were not getting their study done, at least in our institution and our network, and were at risk for delay in diagnosis. Of the 54% we worked on, 33% of those led to a new exam completion, and 41% led to a satisfactory clinical management identification of a satisfactory clinical management, which left us with 14% of patients now who are still at risk, who never got an exam and never had a satisfactory management identified. That occurred for a variety of reasons. About half of that was just patients being non-compliant. Their office was contacting them trying to set up an office visit, or gave them a script and they just no-showed over and over. About a quarter of those people had no primary care provider and didn't want to get one. In about a quarter, there was an issue with the primary care provider disagreeing with the recommendation and feeling that it wasn't medically necessary. We look at something called a reduction in risk of delayed diagnosis. So we think of the baseline as the patients that didn't have exam completion at baseline. So that's the denominator of our equation, and the numerator is those that had new exam completions after intervention plus satisfactory clinical management. So we feel like we've reduced the risk of delayed diagnosis for about 3/4 of the people that entered our tracking system. After that project was deemed a success, we decided to take it from one community hospital to 6 hospitals, including a large academic medical center. Was about 70,000 exams a year to 800,000, and going from about 5 full-time radiologists participating actively to 75 radiologists. So it seems like a good idea. We had a program that was working on a pilot. What could possibly go wrong? And if anyone here has tried to do scale a project like this, I'm sure you could think of a couple of things that might go wrong. So first, we started out getting the message out. So literally, we did grand rounds. We had quality safety rounds. We had electronic distribution of training documents. I went around to primary care providers, radiologists, the whole hospital, every which way we could try to get the message out. We sent out letters from the chairman and the director of the primary care network. And in terms of the number of examinations entered into the system, you'll see in this chart on page 37, on slide 37, the green bar at the top is 1% of all diagnostic imaging studies at our institution. And that was our goal, because that was about what we accomplished at the pilot project site at a single community hospital. We were down here at about 35 recommendations a month, which was about a quarter of our goal after the standard sort of education and rollout of this type of project. So we knew we weren't being as effective as we wanted to be. So we tried to leverage our malpractice insurance providers' participation in the program, and they have a program for a malpractice premium reduction of $1,500 per year for every physician that participated in a risk reduction event. So this program qualified for the risk reduction the risk reduction program if the radiologists would agree to do a 60 to 90-minute training session about why incidental findings need to be tracked and how they would go about doing it in our system, as well as an attestation that they would actively participate in the project, and that they would get data or feedback on the type of recommendations they made and their participation, comparing them to their peers. About 2/3 of our department agreed to participate in this program, and that increased our participation in terms of entering radiology recommendations into the system manually by about 45%. So it was a good gain, but we were still about 1/3 of where we wanted to be. So we're still sort of stuck saying, this program is only giving us about 1/3 of the value that it should be. So then we started working with Bill, getting the clinical analytics tools called natural language processing, where we could read through our radiology reports and identify all of the recommendations, come up with good scorecards to give these radiologists measurement of how they're performing in terms of the type of recommendations they're making and their participation rate in terms of how many they're entering into the tracking system. We got that back to their section chiefs, who could then talk to them about that in their performance reviews. And we can even pull in and cull in some of the recommendations that weren't being manually entered and enter those in on the back end. And that really gave us a 131% increase in the number of cases being entered in the system. We're about 80% of where we wanted to on our goal once we have this. And our real issue now is just that we have radiologists that make less trackable recommendations than we did at the pilot project. So we're identifying all the recommendations now. We just need them to make a little bit better recommendations over time through training. And at that point, I'll let Bill pick up on slide 40.
Great. Thanks, Ben. And first, I do want to thank Ben for allowing us to participate in this fantastic project. Obviously, it's really important to be able to find ways to track down these failed follow-up examinations and get these patients imaged or treated appropriately. So, what is the value of using this tool that Dr. Wandtke talked about previously, mPower Clinical Analytics? On slide 41, the difference between the analytics tool that we've developed here and a lot of the other ones that are certainly out there is the fact that we use natural language processing to extract information out of the full text of the report, right? So these algorithms are radiologist designed, radiologist validated, so that you can actually extract concepts out of the reports to generate these meaningful quality metrics and ultimately improve outcomes and reduce costs. So these types of unstructured data may be, undocumented critical results. It could be dictation errors, such as left-right errors on X-rays, or in this particular case, it's follow-up recommendations. As was mentioned previously, it can be challenging to get radiologists to participate in new projects that require additional steps to be taken. It's already there's already a tremendous amount of work that already needs to be done every day by radiologists. Imaging volume is increasing day by day, and what we want to be able to do is automate the processes of generating quality metrics by allowing the radiologists to do what they normally do, dictate the reports, and automate the process of extracting those follow-up recommendations without the requirement of another of clicking another button or using another application. So slide 42 again just talks about some of the differences between general analytics applications and mPower, which allows you to do this type of full text analysis. So specifically for follow-up recommendations, if you go to slide 43, what happens is every radiology report that's dictated is run through the mPower analytics system and analyzed using our natural language processing algorithms. And if there is a follow-up recommendation present in that report, it will extract the follow-up recommendation and any associated metadata. Was a follow-up recommendation a complete follow-up recommendation with a modality and a date identified? Was it an incomplete follow-up recommendation? Was it hedged? And we take all that information out and put it into our database. And if there was a date attached to it, what we can do is then identify follow-up recommendations which are now overdue. So, for example, if I dictated if I saw a pulmonary nodule on an X-ray or CT on January 1st, I recommend a 6-month follow-up. If it's now July 1st and the system has not detected that a follow-up CT was actually performed, it now moves that examination into the overdue work list. If you go on to slide 44, this kind of shows an example of how this would be done, in that we're able to extract the follow-up recommendation from the free text of the report, put into the database, and then now these follow-up recommendations can be evaluated and reviewed. The other side of follow-up recommendations, again, is to ensure that there is consistency in follow-up recommendations. And if you look on slide 45, this is actually data that we analyzed from a large academic medical center, which showed that there is a considerable amount of variability in follow-up recommendations that are made by radiologists. So on the x-axis, I've anonymized the names, but these are individual radiologists, and on the y-axis is the number of follow-up recommendations that were made. And you can see there's significant outliers on the left as well as on the right, and variability in follow-up recommendations, and over-recommending of studies can also lead to poor clinical care. Over-diagnosis, unnecessary examinations leading to unnecessary cost, radiation, contrast, etc. So we want to be able to use these tools, not only to ensure that we're able to close the loop on appropriate follow-up recommendations, but to also ensure that follow-up recommendations are made appropriately and according to guidelines. And with that, I will hand it back to Dr. Wandtke on slide 46, and we'll go into some of the outcomes.
Okay, thank you, Bill. So on slide 47, you'll see this is a version of our recommendation scorecard that we are now able to, with the data that comes out of the natural language processing tool, to identify a number of different categories. So we can identify the number of unconditional recommendations or those without hedges, and figure out that as a percentage of the volume of the provider's interpretation of a percentage of the volume that they've interpreted over that time period. We send these reports out every month. We identify the number of trackable recommendations. So those are the ones that we really want. Those have the specific imaging modality and a due date, and we set goals for them as a percent of unconditional recommendations they make. So if you make a lot of recommendations, you should also be making a lot of trackable recommendations. And we give people thresholds, goals of 50% or more, or meeting or exceeding goals. And this information gets back to both to the individual radiologist and to their section chief so that they can work with those over time. They also identify the rates of recommendations they're making against their peers. We have, if you see their radiologist 6 in the abdomen section is making a recommendation on 19.5% of all the studies that they read, and another radiologist 5 is making it on 5%, and the average is 7.7%. So it's a way for section chiefs to get some data on their outliers and start to work with them. And we can provide actual recommendations that they're making, so specific examples back to them very easily, so that they can look at some of the terminology and change the way they practice. We also track how many that they've manually entered into the Backstop system, so that we know who's actively participating in the project. And we separate these out by sections because you'll find that different types of radiologists have very different recommendation patterns. So it's very uncommon for pediatrics or musculoskeletal radiologists to deal with incidental findings, but very common for thoracic and body imagers and radiologists working in general sections or emergency department to see lots of incidental findings. So we talked about expanding the project to the entire health system. So we did that starting in July of 17, and we've been going now for over a year. We got data mostly from the first 9 months here. We are on pace now tracking about 500 recommendations a month coming out of our system. The baseline exam completion rate is 55%, so it's a little better in the integrated health network, and that's primarily related to the fact that we have access to electronic medical record reports of more patients, so we can get more closure events than were simply clinical closures only at baseline. Of all the cases we intervened upon, though, so the 45% that weren't completed at baseline we intervened upon, 36% we got a new exam completion after we did our interventions. Our stage interventions that we talked about before. 42% had a satisfactory clinical management, and that left us with 9% with unknown follow-up compliance, and I showed you our risk reduction metric that we use. So we were able to reduce the patients at risk of delayed diagnosis by 80% by putting them in the tracking system. So we actually exceeded our pilot project in terms of the success of doing this at a large scale once we had the natural language processing tool in there to allow us to get the recommendation entry up to where it needed to be. So the overall outcomes, we increased examination completion rate from 55% to 71%, which improved both patient outcomes and reimbursements, and reduced the number of patients at risk for delaying diagnosis, which is the medical legal aspect of this issue. So one or two lawsuits can affect a health system to a much greater degree than the cost of implementing one of these tracking systems. We get about 80 new exam completions a month. 60% are CT, another 15 to 17% are MRI. Those exams more than cover the cost of the tracking system, both the medical informatics tools and the labor to run it. We actually feel like we have a positive return on investment on this. And so, we feel like we'd be leaving money on the table if we didn't track our recommendations, in addition to the fact that it's simply providing better care, and none of us want to see that next patient come through with an advanced stage cancer when we should have identified an early stage cancer. Slide 51, I want to show you another patient case. So this is somebody that came into our health system now 5 months ago. They came to the ED with shortness of breath. Again, had identification of a left lung nodular density that was worrisome for potential cancer. We made a recommendation to the ED doctor for a CT follow-up, and we communicated it and documented it in our radiology report, just like we did for the first case. We also put it into the Backstop program this time. So the patient didn't come back that day. They didn't come back next month. So after 1 month, we identified that they still hadn't had the follow-up, so we resent the radiology report to the office. A month later, the primary care provider still hadn't ordered that test. So now our navigator called the care manager, spoke with her. She was very helpful. And our navigator remembers this conversation, and she said, sure, I'll work on it. They scheduled an appointment for the patient to come in to see the doctor. Took about 2 weeks. The doctor gave her a script another week or two before they got the study done, but ultimately got the CT done. We identified a 2 centimeter to 2.5 centimeter spiculated nodule that was worrisome for cancer. They followed up in short order with a PET CT, which identified a hypermetabolic nodule, which was consistent with cancer, but no metastatic disease, so no spread to lymph nodes or other areas, and it was ultimately diagnosed with stage 1 lung cancer. So same type of presentation, different type of tracking system intervention, safety net in place, and it led to a different outcome for that patient. So a couple of take-homes. One is it takes a team to do this. No individual is going to set this up, but that's the goal of coordinated healthcare, to just create a system that's safer for all of our patients. We led it through radiology, but it is a health system initiative with our vice chair of quality and safety as an administrative sponsor, and our primary care director is also as a major sponsor of the program. We had a full-time equivalent for clerical navigator. This is for a system with about 800,000 DI exams a year, and we had a 50% project manager to help with some of the research aspects and help with some of the clinical issues and the education, both the providers and radiologists. We worked with the Nuance team both in database development and in the clinical analytics tools to allow us to automate a lot of the steps and make this more efficient. On slide 58, you'll see that we wanted to work together with our primary care providers and other care providers in our organization to manage these recommendations. We feel that the health systems can dramatically reduce preventable delay in diagnosis of malignancy, and we think we're doing that every day now. And our vision statement for the project is that every patient deserves their best chance for a cure. So whenever time we're struggling, my navigator feels like she's made 1,000 phone calls in the last 3 months. She goes back to these cases where we've made a difference and remembers that we're really making a difference. So we're aiming for 0 patient harm. It's obviously almost impossible to reach that, but we're really reducing. We feel like we're reducing the amount of patient harm that exists in our system, and I hope that you'll consider doing a similar type of project in your system, managing your recommendations as well. So thank you for your time, and hopefully we have some time for questions.
Well, that's great. Well, thank you so much, Ben and Bill, for providing this interesting example of what it takes to combine analytics and then just the follow-up of making sure that these kinds of incidental findings get acted on and do reduce the risk of people not being properly diagnosed. So thank you for sharing this insight. A reminder to everyone that's on the phone, simply press 5* on your telephone keypad, and we will unmute your line and invite you to ask a question, perhaps share a project that you're similarly undertaking at your organization, or drill down in any aspect of the discussion so far. So just press 5* on your telephone, and we will unmute your line. And maybe just to kick it off while we're waiting for people to join the queue, could you just describe in a little bit, obviously you gave us a good example of here's the process of how you changed getting people to get engaged in this process with communication. Then you added a financial incentive in terms of medical malpractice, and then look at the huge increase that you gained by using this analytics tool. But can you provide just a little bit more context for why was this analytics tool, in particular the use of the natural language processing tool, why was this so important as the way of really getting at what is inherently a care process follow-up issue?
Sure. So this is Ben Wandtke. So I think that the analytics, in order to do recommendation tracking at scale, you're asking 75 individuals who don't directly report to whoever's in charge of this quality program probably to change their workflow, to go out of their way and make extra clicks. There are people that are trying to do this in the electronic medical record environment, so that ask the radiologist to leave the EMR and go into the electronic medical record. there, I said we were about a quarter or a third as effective as I wanted to be in our recommendation entry mechanism manually by the radiologist by leaving it in the PACS environment. They're getting much worse results by asking people to go out into the EMR and enter cases manually into those environments. It's simply changing the way people practice. It's changing the culture. You can preach the mindset, but people get busy in radiology, and people are used to, they're asked to read 100 cases a day, and it's one extra workflow. And as much as recommendations exist in 4% of all the radiology studies in our institution, the ones that meet our inclusion criteria are really more like 1% of all of our studies. So you're asking to do something very rarely on a consistent basis, and it's human nature that it's difficult to do it. So, and if you're not giving them metrics or measurement or having a scorecard in order to help them modify their behavior and or their supervisors to manage their behavior, you're really not going to win that battle. So the natural language processing clinical analytics gave us the ability to create a scorecard, and it gave us the ability to create an automated way to bring in recommendations, to identify those that were not identified manually by the radiologist at the time of their dictation. So for those two reasons, I think it's critical to have the analytics tools when you're trying to do this type of system at scale.
Mm-hmm. Well, thanks for adding that clarification. And again, a reminder, invite anyone on the phone to simply press 5* on your telephone keypad, and we will unmute your line, have you join the conversation, perhaps share any other lessons learned that you are undertaking at your own organizations around this critical issue of improving diagnosis. So any questions or comments, just press 5*. So maybe just to Bill, again, while we're waiting for other callers to come in, how about if you just drill down a little bit more around the analytics driving quality and outcomes, quality and cost outcomes. You certainly talked about how this is improving the risk, reducing the risk of delayed diagnosis. But how about, have you been able to actually track some of these individuals? You gave that one example at the end, but certainly with someone who 3 months later was tracked that otherwise would have fallen through the cracks. Other ways that you're searching out anecdotal stories or other kind of metrics to really drive at what's the quality impact of this improved approach?
So obviously, outcomes research is what everyone's looking for. At least that's the hot topic in radiology, and we are having as you move to value-based systems of care, we're all being asked to identify ways we add value and to measure that and to do that, effectively. We don't do a great job in radiology of measuring or identifying our value. This is one of the areas where I think we have a chance to do so. The field is relatively new, and the metrics and measurements haven't been set by by the American College of Radiology or others, because people are really just getting into it. We're a little bit ahead of the curve at the University of Rochester. I think we are going to be able to do that and do that well by the database that we have. We have now data on a few thousand patients that have come through the system. We want to create an automated way to link the results of pathology reports back to radiology recommendations that are made. There are some tools that are out there that assist with what we call peer learning or education of radiologists in terms of follow-up of what they see. There's ways to use natural language processing to do that. I don't have access to that tool at my institution yet, but we do want to get closer to outcomes. I think we're moved beyond communication into exam completion, and as long as these recommendations are being made consistent with an evidence or consensus-based document, that's going to reduce variability and get us much more likely to have positive impacts on patient outcomes. We're limited right now to anecdotal stories of success, but I guarantee you once we're gathering the data now, and we're going to be able to make the story soon about the overall outcome that we're having. So it's a goal of ours, but we're not 100% there yet.
Well, that's encouraging. And as long as as you pointed out, we are in Lung Cancer Awareness Month if you focus in particular around lung cancer, when do you think we'll start to see that shift in outcomes overall as a result of being better able to diagnose the disease?
So I also lead population health initiatives for our hospital, and one of the big issues is CT lung screening, and the fact that utilization of CT lung screening is, they've had some recent research that shows it's, nationally is potentially as low as 3.5% of all eligible individuals in this country, which is woefully low after a system that's been in place for 5 years and much lower than the 60 to 65% screening rates you see for mammography and colon cancer. I think that test has a dramatic ability to reduce lung cancer mortality. That lung cancer mortality is already decreasing due to efforts in smoking cessation that really were spearheaded in the last 10 to 15 years, but it still remains the leading killer of both men and women on the cancer side. I think this incidental nodules tracking will also have a significant impact. You put smoking cessation together with CT lung screening, together with incidental findings tracking, and I guarantee you if you start looking at cancer registries, we're going to see a significant shift in the percentage of patients presenting at early stage cancer versus late stage cancer. Trying to sort which one of those is having the most effect out would take large populations and some complicated math, but I think it can be done and probably will be done over time.
And as you extend this into the population health arena, are there other opportunities that you can see using this analytics approach to address other areas where we're missing diagnoses, or we need to either improve the way we do diagnosis or again, these incidental findings for follow-up? Where else would you see the opportunity for expanding this outside of this case example?
I think maybe I'll let Bill try to tackle that one.
Sure. No, I think that there are a number of, beyond lung nodules, probably the next one that we'd like to really tackle are aneurysms. The number of incidentally noted abdominal aortic aneurysms that are not followed up on is also fairly significant and can lead to very poor outcomes if not treated. We're in terms of the next stage that we're taking this, we're going to try and address some of the issues of appropriate follow-up recommendations by adding in the ability to analyze not only the presence or absence of a follow-up recommendation, but also quantifying the size of the lesions right in the report, so that we can. If a 4.5 centimeter or if a 5.5 centimeter abdominal aortic aneurysm was dictated in the report, but there was no follow-up recommendation, right? What we are going to be showing at this year's RSNA is the ability to extract the concept that there is an aneurysm or a lesion of a certain size and that should lead to a certain type of a follow-up recommendation, even if that was not explicitly dictated by the radiologist. So as we get more intelligent with the way we're able to extract information out of reports, I think that this will hopefully lead to more appropriate recommendations, more appropriate care, and closing the loop to reduce these cases of delayed diagnosis.
Well, we certainly appreciate all of this work that's going into it. I know that this topic of wrong or delayed diagnosis is a very important and critical issue for us all to address in our hospital. So thank you for providing this insight. Again, if anyone else has a question or a comment, just press 5* on your telephone keypad. And Robin, do you show any other callers at this point in time in our queue? Okay. So we don't have any other callers, but we really appreciate you bringing this to our attention, and thank you for this very rich explanation of how advanced analytics can really help us address this wrong or delayed diagnosis issue. So do you have any final closing remarks, Ben or Bill, before we wrap up for today?
No, again, I appreciate everyone participating today in today's conference. Thank you very much, Ben, for that very insightful talk. And if anyone on this call is looking to find more information, you'll find our email addresses at the beginning of the presentation.
Wonderful. Thank you so much. We appreciate it. Sorry, I
guess I'd just make one comment that, there are not every quality program can pay for itself, and it's hard to get some of these programs funded or paid for in the current tight health system that we're in. This is one of the programs that is kind of a triple win. It's a win for everyone involved if you do it right. It improves the care for the patients. It brings in revenue that keeps all the people that are responsible for the finances of the health system with a positive return on investment, and it reduces the malpractice risk and litigation for the health system. So everybody from every different angle is kind of winning on this. It reduces malpractice risk for both radiologists and the office-based providers, ED docs. So there's not a lot of programs out there in terms of quality that everybody kind of wins if you present it the right way and perform on it the right way. It's a bit of it takes a little bit of effort to get it up and running, but with some of the work we've done early on, we've worked with Nuance here to get a system that would make it easier for other people to get up and running and to do a similar project at their institution. So I think this is very much manageable to do, and it can be a win for everyone involved in your health system.
Wonderful. Well, thank you so much for sharing your insights and your progress, and we look forward to hearing continued results over the course of the next few years. So thank you so much, both of you. And for everyone that's on the phone, please take a minute to complete the post-teleconference survey. And we look forward to hearing everyone back again on the next Scottsdale Institute teleconference. Thanks, everyone, and have a wonderful day. Bye-bye.